I would like to start with the first speaker, with Agneta. Just have one question about the strengths of the repair. It means stability of, this is of course not the restoration of the midline, the linea alba. It's a kind of bridge repair. So that means, is the scar really stable? Is there a bulge? Did you see a bulge in the long term? Or what?
No. You don't see a bulge, and plenty of these patients have had CT scans afterward, and you sort of put it under traction, so it really integrates, and the scarring properly. It doesn't look. I don't see any bulging.
Just one question. You had an infection rate, mesh infection rate, 11.3%. Use it in both groups, the same mesh, I suppose. Why that? Do you have any comments on that?
The Dynamesh has been used consecutively in the later group. There are some polypropylene in the other groups as well, but all no mesh have been removed.
Okay, but you don't have an explanation for that, the difference of the infection rates?
The contamination from the different patients, they are, most patients are heavily contaminated. So if you could say one or the other cause, it would be impossible. I would say it's a case series. But it heals and it works.
Yeah. Ramana, please.
My question to Agneta is that there is, I think, enough data available today, and there is a broad consensus that in all AWR, the chances of recurrence are higher in those where the midline has been bridged. I think this has come from individual institutional studies as well as from systematic reviews of the literature. But when it comes to the peritoneal flap, I'm sure you find good results in your patients, and the Edinburgh group has published 5-year results with very good outcomes. My question to you is, where is the gap? Why is it that outside these studies, bridge repairs have higher recurrences, whereas your cases do not have higher recurrences?
That's hard for me to explain, but the techniques and the overlap of the meshes might be the difference. I don't know, but still the gaps are limited, and being this wide down to this, so there is a limited gap, I would say, but still there is, but not in all. But still it's closed with a peritoneal flap, so it's in a package. That might be the answer.
I have 3 questions, one for Antonio, one for David, and one for Jorge.
Okay, the 3 last questions. It's good for us.
So, Antonio, Espinosa de los Monteros. The original technique, Albanese and Ramirez, in anterior component separation, was performed without mesh. Regularly, do you place a mesh or not in the anterior component separation? And what exactly is the indication for mesh placement or to avoid to place mesh? Shortly.
So historically, the anterior component separation was designed to close the abdominal wall in patients that were not desirable to use mesh. In the times where mesh was usually placed as a bridge for large defects. After that, it was shown in the world that great outcomes are obtained if we close the abdomen and add a mesh. And in my particular experience, I can get a better mesh placement if I use a TAR, as opposed to an anterior component separation. So if I am going to use an anterior component separation, is because I am not going to use a mesh, because if I am going to use a mesh, I will prefer to do a TAR. Because several reasons. One, the mesh is extraperitoneal, is not subcutaneous, has a wide overlap, and it follows the principles of reconstruction in every part of the body. I am a plastic surgeon, and usually we see as plastic surgeons that the best reconstructive outcomes are seen in any part of the body when there is an internal lining, which in this case is the posterior rectus sheath and the transversalis fascia. And then we have a strong structure. It may be bone, cartilage, an implant, depending on the part of the body. Here it is a synthetic mesh. And then we have muscle coverage of that strong prosthesis. And then we have a good subcutaneous padding and healthy, well-vascularized skin. So in the setting of abdominal wall reconstruction, the technique that fulfills all these reconstructive grade requirements is the TAR. So that's why every time I face a large hernia, I prefer to use a TAR. If I cannot use a mesh because the scenario like I showed, then I will use an anterior component separation. So these days, I will not pair just a traditional anterior component separation with a mesh because I cannot find a perfect mesh placement in the setting of anterior component separation.
Thank you. David, your attitude in general regarding the previous mesh, because your presentation was about recurrence. Would you replace, would you remove the mesh in general? What is your attitude? Or you keep the mesh inside and you place another one?
Yeah, that's a very good question, what to do with the old mesh. And in my practice, which may be different from others that do a lot of this, it entirely depends on if there is a problem with the old mesh. Okay, so if mesh is involved with bowel, if there's any question of mesh infection, if the mesh is contracted and pulling on tissues or nerves and causing pain, if the old mesh is balled up and getting in the way of me laying a nice, proper, flat, contoured new mesh, then that mesh comes out. Okay, sometimes it may be a portion of the mesh. If the mesh is causing no problems, and typically if the mesh is forming a new layer, for example, if I leave the mesh with the peritoneal flap and it is not bothering the patient, they're only here with a recurrence, then I create more destruction by trying to remove that mesh and having a big gap posteriorly in the posterior layer, so I will leave that in place. I know there are others that do a lot more of this than I do, whose philosophy is to generally take out, the mesh. Yuri would tell you he tries to get out the old mesh, but that's not my practice.
Thank you. Jorge, in lateral hernias, one of the big challenge is to catch the fascia of the external oblique in your suture. Do you have some advice or tricks for this? Because the reconstruction couldn't be so solid without this fascia.
You mean in ventral hernias, right?
No, I mean lateral hernias often is difficult to see, to identify, and to catch the fascia of the external oblique muscle.
Yes, it is.
Do you have some advice or tricks for this to avoid this weakness, in fact?
Yeah, well, if you have a combination of weakness and hernia, I would do a hybrid approach. So I can solve both problems, minimal invasive and the problem of cosmesis and closing the anterior fascia, I can solve it with the open part of the procedure. In giant hernias, even if they are not weakness, I prefer to do it open for sure because of the same problem. But for this kind of hernias you've seen, usually 5 to 10 centimeters, you can close it comfortably and identifying the borders of the defect perfectly, I would say. You have to choose if you have to close it longitudinally or transversely, and sometimes there is a trick. I don't know if Antonio mentioned that, but you can do an endoscopic anterior component separation, as we do on the other side, and it has effect even at that level. It helps you close the defect. You don't have to close it on the same side. But that's a trick we can discuss later.
Yes, just only to remark, Jorge, that probably primary or small lumbar hernias, the main defect is in the transverse abdominis muscle, because the Greenfield and the both primary lumbar, Greenfield and Petit, were always described from outside, not from the inside. And now that we have the laparoscopic view, we can see that the defect is primary in probably in the posterior aponeurosis of the transverse abdominis muscle that was also shown yesterday nicely by the anatomical review talks. So probably it's enough to close the transverse abdominis muscle, but mainly with previous incisions, and could be a big task to take the external oblique and internal, because in lateral defects we have 3 holes at 3 different levels. So maybe sometimes we have a defect on the transverse abdominis, but also in the internal at the same level, but the external oblique is even bigger than what we see from the inside, and that we need to make like a hybrid or something.
Yeah, and maybe it's not so important in these small or medium-sized hernias, because they don't behave as the medial hernias. The medial hernias are progressive because of the forces of the abdominal cavity, the physical forces take you the borders lateral. But when you are lined up by bone very posteriorly, that is not a progressive hernia usually. If you close enough and put a mesh, it's enough for most cases.
Yes, sorry, because I want to take the advantage that you're here. And talking about when you place the patient in the lateral position with the bed flexed, when you're placing the mesh, do you change the position? Do you flatten just you put it over there? Okay, that's.
I can go as far as I can. I can go as far lateral as almost the column.
The quadratus, yeah.
Yeah,
Okay.
all the way to the paraspinal muscles.
Yeah.
You can go that.
Yeah, because sometimes I'm concerned about that if you don't unflex the mesh, maybe the mesh could be bulge, because of the position of the.
Yeah, it can wrinkle. You have to make sure.
But it's true that for small defects could be more than enough to make that work.
That is a good point.
Okay.
Closing muscle is important, yes. So it will be the last word. Thank you for everybody, all speakers. Thank you for you. It's coffee time.